Welcome. Good afternoon. My name is Jeff Resnick. I'm Chief of the History of Medicine Division at the National Library of Medicine. Thank you for joining us today to hear the 12th Annual James H. Cassidy Memorial Lecture in the History of Medicine, which is part of the National Library of Medicine's 2021 History of Medicine Lecture Series. This year's lecture is co-sponsored by the National Endowment for the Humanities, Office of Digital Humanities, as part of the NLM's ongoing partnership with that agency to collaborate on research, education, and career initiatives. Thanks very much to our colleagues at the NEH. And for all of you following on Twitter, thanks for following along using the hashtag NLM HistTalk. So for the past dozen years, the National Library of Medicine's History of Medicine Division has been hosting this special lecture in memory of our late colleague, Dr. James H. Cassidy, renowned historian of medicine, 50-year employee of the NLM, an editor of the printed bibliography of the history of medicine, and a great supporter of many essential research tools valued by generations of scholars. During the course of his distinguished career, Dr. Cassidy received every major honor that the National Professional Society in his field, the American Association for the History of Medicine, could bestow. In addition to the Welch Medal, which he received for his books American Medicine and Statistical Thinking, 1800 to 1860, and Medicine and American Growth, 1800 to 1860, he was awarded the association's Lifetime Achievement Award and delivered its honorary Garrison Lecture. He also served as president of the association from 1982 to 84 and worked passionately on its many committees. With respect to our former colleague, therefore, it is my great privilege to introduce today's distinguished speaker, Dr. Naa Oyo Kwate of Rutgers University, where she is Professor of Africana Studies and Associate Professor of Human Ecology. A psychologist by training, Dr. Kwate is a native of Chicago and received her PhD in clinical psychology from St. John's University in Queens, New York. She completed her postdoctoral training in cancer prevention and control at Mount Sinai School of Medicine and subsequently held a faculty position at the Mailman School of Public Health at Columbia University. Dr. Kwate's research centers on the social determinants of African American health, investigating how urban built environments reflect racial inequalities in the United States and how racism directly and indirectly affects African American health. She is recipient of a National Institutes of Health Directors New Innovator Award in 2009 and the Robert Wood Johnson Foundation's Investigator Award in Health Policy in 2008. Her research has also been funded by the Robert Wood Johnson Foundation Healthy Eating Research Program, as well as its New Connections Initiative. It's also been funded by the Department of Defense Breast Cancer Research Program. And notably, she's a recipient of a 2017 NLM G13 Award for scholarly works in biomedicine and health publications for her project entitled Race and the Transformation of the Food Environment, Fast Food, African Americans, and the Color Line, 1955 to 1995. The book funded by this grant is nearing completion. As well, Dr. Kwate's NLM-funded research produced a 2019 publication from the University of Minnesota Press entitled Burgers and Blackface, Anti-Black Restaurants Then and Now. This volume will join an extensive series of publications by Dr. Kwate, including another forthcoming book, edited by her and with photographs by Camilo Vergara, entitled American Inequality, a photographic field guide in the streets of Camden. This will be published by Rutgers University Press soon. She's also author and co-author of many articles in journals such as the Du Bois Review, Social Science and Medicine, Applied Geography, Health and Place, Race and Social Problems, and the Journal of Urban Health and the American Journal of Public Health. Dr. Kwate directs the Race, Neighborhoods, and African American Health Lab at Rutgers, and you can learn more about her research through the extensive website of her lab, which you can find at rna-lab.com. Please join me in welcoming Dr. Kwate to the National Library of Medicine to deliver our 2021 James H. Cassidy Lecture entitled Savages Cry Easily and Are Afraid of the Dark, What It Means to Talk About Race and African American Health. Dr. Kwate, welcome, and thank you very much for joining us today.
Thank you, Dr. Resnick, for quite the introduction. It's great to be here, and I want to thank also everyone else at the NIH that made this talk possible today, including Lindsay France, who's advancing my slides for me, and the ASL interpreters who are making the talk accessible to more participants. So I'm really delighted to be here. As you heard, I have the fortune of being an NLM grantee for a book project, as Dr. Resnick mentioned, and so I'll be describing that later in the talk. And the title for today's talk comes from my having come across this text that was in the NLM's digital collection. So I'm going to say more about that starting on the next slide. But first, I kind of want to just give the punchline for the talk up front. And so that what it means to talk about race and African-American health, in fact, it's really health risk. But what it means to talk about African-American health risk is to talk about racism. So Dr. Rhea Boyd and colleagues wrote eloquently on the Health Affairs Journal's blog in July 2020 that, quote, "Racism kills. Whether through force, deprivation, or discrimination, it is a fundamental cause of disease and the strange but familiar root of racial health inequities," end quote. The authors throw into bold relief the relative absence of interrogating racism in the medical literature, but instead talking about race, typically in ways that invoke biological understandings of health disparities as something that, predisposes African Americans to genetically to disease. So such studies conceptualize racial disparities, perhaps not in language as stridently racist as we would see in early 20th century race science, but they locate health outcomes in psychological, behavioral, cultural kinds of defects nonetheless. Next slide. Okay, so this is the book that I saw in the NLM collections. It's entitled Savage Survivals, written by a J. Howard Moore and published in 1916. So the book has no introduction, so I don't know what the overarching argument of the book is. I found it while I was doing research in the collections, looking to see if there were documents related to health and eating. And so in part 3 of the book, which is called The Origin of Higher Peoples, the author states that some races have changed significantly over evolutionary time, while others have not, and they lag behind and remain in a fixed state. So Moore contends, quote, "We call these latter savages. Savages are merely people who are in the infant stages of human development. They have never grown up. They are child races." He goes on to say that Africans are either savages or they are in the stage of barbarism, which is in between savagery and civilization. Quite in contrast, quote, "The race which has been most talented and enterprising and which has played the most distinguished role in the affairs of the world has been the white race," end quote. So Moore continues in that vein and makes an assessment of the savage temperament as follows, quote, "Savages cry easily and are afraid of the dark. They are fond of pets and toys. They have weak wills and feeble reasoning powers. They are notoriously fickle and unreliable and exceedingly given to exaggeration of their own importance," end quote. The propensity to see Black people as pathological, backward, irrational, and is ultimately responsible not only for the health inequities that they face, but also for causing a drag on the nation's resources, have unfortunately gone nowhere or not gone anywhere. Next slide, please. In June of 2020, the media reported on remarks made by an Ohio State Senator, Stephen A. Huffman, during a hearing of the Senate Health Committee, which was actually about whether to declare racism as a public health crisis. Musing about the reasons Black people might be more susceptible to COVID-19, he stated, quote, "Could it just be that African Americans or the colored population do not wash their hands as well as other groups or wear a mask or do not socially distance themselves? Could that be the explanation of why the higher incidence?" End quote. Dr. Whitney Laster-Pirtle, in a paper on racial capitalism and inequities in the COVID-19 pandemic, points out that in Chicago during the 1918 flu epidemic, racial tropes were used to blame the spread of disease on Black residents. To see the same tropes and even the same racial designation, colored, revived today reveals how deeply entrenched these ideas are. Classic texts such as Racism in Psychiatry by Thomas and Sillin and Guthrie's Even the Rat Was White document the long history of scientific racism, which promulgates ideas about Africans or Black people's inferior intellects, abnormal personalities, lack of impulse control and judgment, and on, all of which were thought to be fixed traits. And so these theories cast their long shadow in the contemporary moment in differential psychiatric diagnoses. So for example, Black patients are more likely to be diagnosed as psychotic than as having a mood disorder such as depression. Other inequities that we see include African Americans' lower probability of receiving opioid pain medication, or really receiving pain medication at all. A legacy of persistent stereotypes about higher pain thresholds among Black people, and as well as stereotypes around criminal drug sinking. Next slide. So the state senator gave what he called an apology for his remarks in a statement in which he explained, quote, "Regrettably, I asked a question in an unintentionally awkward way that was perceived as hurtful and was exactly the opposite of what I meant," end quote. So whatever critique he faced, and apparently he was fired from his post as an ER doctor, it was not enough to keep him from being appointed to lead the panel tasked with reviewing legislation about health and human services for the state of Ohio, which is what we see being reported here on the slide. Next slide. And so in that same article that I just referenced by Dr. Pirtle, she cited an interview with Dr. Uche Blackstock, an emergency physician in New York City. And so she had appeared on the PBS NewsHour and was expressing concern about what was going to happen when Black and brown individuals presented to the ER with COVID symptoms. And she was concerned that, quote, "their symptoms may be downplayed or they may not be taken seriously," end quote. Indeed, that fate befell Dr. Susan Moore, a Black woman and physician who died despite her expertise as a doctor and her ability to advocate for her healthcare, reported here by the New York Times. And studies have shown repeatedly that Black patients receive disparate care, especially with regard to their symptoms not being taken seriously and their pain and suffering being discounted. Black women in particular, who are stereotyped as angry and aggressive, are likely to be seen, metaphorically speaking, as savages who cry easily and are afraid of the dark. Next slide. Controversy also emerged in April of 2020, when then Surgeon General Dr. Jerome Adams, during a coronavirus task force briefing, seemed to suggest that Black people needed to generate particular kinds of self-regulation and self-monitoring, and that the onus was on them to flatten the curve of infection. Having noted that Black people comprised disproportionate numbers of deaths in relation to their proportion in the population, he asked, quote, "So what's going on? Well, it's alarming, but it's not surprising that people of color have a greater burden of health conditions. African Americans and Native Americans develop high blood pressure at much younger ages, and it's less likely to be under control and does greater harm to their organs," end quote. But pointing out more severe burdens of health conditions, such as high blood pressure, does not actually take the blame off African Americans, for whom pervasive narratives find them at fault for failure to take appropriate responsibility for their own health, or to willfully engage in behaviors that foster chronic illness, which we'll return to later. Adams acknowledged that only about 1 in 6 Black people were likely to have jobs where they could work from home, but he still went on to say that they should stay home if possible. Cautioning communities of color in particular, he declared, quote, "The government will be doing all it can day and night to protect regardless of color or geography. It's even more important that in communities of color, we adhere to task force guidelines to slow the spread. Avoid alcohol, tobacco, and drugs, especially in communities of color. We need you to step up and help stop the spread so we can protect those who are most vulnerable," end quote. So this is an odd comment for many reasons. Certainly, not using these substances can support overall health, but obviously these are not behaviors immediately linked with infection risk from an airborne pathogen. Cautioning especially communities of color to avoid these substances merely reifies stereotypes of wanton and endemic drug use and suggests a need for the government officials to attempt to try to keep them in check. Lacking in this analysis is a consideration of what sociologists Drs. Bruce Link and Joe Phelan define as fundamental causes of health. Fundamental causes are distal, not proximal drivers of health, like smoking or drinking. Fundamental causes determine access to resources, money, power, prestige, knowledge, and more, that shape the likelihood people fall at risk of health risks. They determine the likelihood of being ill and how well people can recover from any illness that they do develop. And they also affect multiple disease outcomes through multiple pathways. Next slide. So if we're going to talk about tobacco, missing from the Surgeon General's statements is a recognition of an important distal cause, that of aggressive marketing of menthol cigarettes to African Americans. This image is from Baltimore in the 1980s. The Master Settlement Agreement in 1998 prohibited outdoor advertising for tobacco, so you won't see ads like this anymore, but when you did, they were disproportionately located in Black neighborhoods. And the focus was on menthol cigarettes like Kool advertised here, as well as Newport and Salem. And so this could be a whole talk in itself. Historian Keith Waylu has a book coming out on this, which I'm eagerly awaiting. But the tobacco industry has reaped huge profits from targeting Black consumers. And much of that targeting took place in the built environment and still does to us at a smaller scale in point of purchase advertising. In 1984, marketing experts saw Newport as having success due in part to its strength in outdoor advertising, which they found, quote, very effective in appealing to a Black audience, end quote. Indeed, Laura Lard, R.J. Reynolds, and others relied heavily on this advertising medium, which capitalizes directly on segregation and it's making a captive audience of Black residents. Segregation also made possible Newport's inner city van program, where company representatives would drive through the neighborhood, set up on a street corner, play music, hand out cigarette samples, and so on. But to hear it told from Newport executives, quote, it's not that Newport went looking for those groups, it's just the way it happened. In fact, menthol cigarettes are more hazardous than non-menthol, contain more nicotine and tar, contain additional carcinogens, and the cooling sensation of menthol causes users to inhale more deeply, which increases the intake of toxins and makes the cigarettes more addictive. Taken together, decades of aggressive marketing in the built environment lay the foundation for lungs that are vulnerable to COVID. Next slide. And if we really wanted to think about alcohol and African American health, then we would need to question the presumption that there's a higher propensity to drink that requires singling out, as the Surgeon General had. In fact, health data has consistently shown that compared to white counterparts, Black Americans are less likely to drink. So this is data for adults aged 18 or older from the National Health Interview Survey. This is from the 2015 survey. And so if you look on the left side of the graph, you can see that Black respondents, who are the yellow bars, are actually more likely than white counterparts to be lifetime abstainers from alcohol, right? So they're not, they have never drank alcohol. And then on the right side of the graph, if you look at white respondents, who are the green bars, they are more likely to be current regular drinkers. Next slide. And these same patterns bear out in consumer expenditure data, such that African Americans spend less on purchasing alcoholic beverages. So this is a map showing alcoholic beverage spending across the New York City metro. This is from 2017. And so the darker the shading, the higher the expenditures, and the darkest areas are predominantly white. So there's a significant mismatch between consumer behavior and where the liquor stores are and where the outdoor advertisements for alcoholic beverages are. Next slide, please. Black communities have resorted to what has been called whitewashing, where residents paint over ads. It was a frequently used tactic in the 1990s and led to outdoor advertisers making concessions that they would refrain from advertising alcohol, and again, at the time, tobacco, near sensitive sites where youth gather, such as schools, churches, and playgrounds. They don't actually adhere to these guidelines, but this is what the kind of self-regulatory mechanism they purported to use at the time. So this is a phone kiosk I took a picture of in Brooklyn around 2005. Next slide. And then this is the other side of that same phone kiosk. So what's hidden behind that cardboard is a Heineken bottle. This is an ad for Heineken beer. And so you can see the tagline still at the top, what's really good. And then there's something else at the bottom, which is cut off, but it says it's all about something. And then to consume, it encourages you to consume Heineken responsibly. And so now, of course, there aren't really phone kiosks because everybody has cell phones. So most of these in New York have been changed into, I guess, like Wi-Fi hotspots and phone charging stations and so on. Okay, next slide. But something we never saw back when they still had phone kiosks in Black neighborhoods at the time in central Brooklyn and in Harlem were ads like these for water. So this is a photo that I took in Chelsea in Manhattan. Next slide. And so this was taking place during a study. Myself and several students worked with me on Project Reach, which was a study of the separate influences of the alcohol environment and also experiences with racism on alcohol consumption among Black women in Harlem. Next slide. And this is a map of outdoor advertising in central Harlem. So each dot is an ad space. So whether it be, you know, phone kiosk or other kinds of street furniture and other ad panels. So we gathered information on all the standard outdoor media by basically walking up and down the streets throughout the neighborhood and recording the location of each ad space, counting a total of 534. So that's what you see here. And then after we had mapped out where the ad spaces were, we returned to see if they contained alcoholic beverage advertisements. Next slide. And here's a sample of the kinds of ads we saw and the outdoor media formats in which they appeared. Again, some of which are now obsolete, like phone kiosks, but others are not. The biggest ones are the wallscapes, which elevate bottles of liquor in the sky to be among the most visually prominent features in the neighborhood. So on the top middle square there, with this ad saying "Still Real," featuring Fat Joe. So this is a wallscape, and to give you a sense of the scale, if you look to the top corner, right corner, you can see there's scaffolding there, like that people use, for example, to clean windows and so on. In this case, probably to put up the ad. But when you see how small that scaffolding is in relation to that wallscape, it gives you a sense of just how big that ad is. And then similarly on the top row, but on the right, the Tanqueray ad, which is covering these apartment windows. Supposedly, you're supposed to be able to see out from behind the ad. I don't know if that's actually true. In any case, that's what they say. But what you can see is that the ad is 4 stories tall, right, in terms of the windows that it's covering. So the pervasive marketing of alcohol is a toxic exposure because, of course, it's a product that can be toxic to health. But beyond that, the images and messages used in the advertisements themselves represent a toxic exposure. Thematically, Harlem residents were mostly asked to consider intoxication as a means through which to move across class boundaries, express an authentic Black self, and pursue the good life. As well, the use of sexual imagery and themes has particular salience given the ways in which Black women embody deviant sexuality in the American imaginary. Again, these are long-standing kinds of racial tropes and stereotypes. So on the bottom right, for example, we have an ad for Colt 45 malt liquor, echoing the advertising campaign from the 1980s, which was "The power of Colt 45, it works every time," a message then delivered by the actor Billy D. Williams. So here, the shorter message, just every time, is no less explicit, right? Colt 45 is a catalyst for the acquisition and sexual domination of ready and available Black women, is what this suggests. Next slide. And then I just want to highlight this ad, which was on the bottom row for Courvoisier. This is an expensive cognac at the time. When we did the study, it was retailing for about $144 per bottle, and those bottles are not large. And so this was being marketed in a community where the median household income at the time was about $20,000. The ad suggests that, okay, so the ad says you can achieve anything in America. Well, almost. So what does that mean? Well, it suggests that while the long sought goals to achieve justice and equality in America are so dear to Black residents, not only in Harlem, but indeed everywhere else in the country, those things might be just beyond reach, right? But consuming an expensive alcoholic beverage is not. Next slide. And then here's another in that series, and the same idea here. If this gentleman would just look up, he could be having a totally different and better life. Next slide. Okay, so then what did exposure to all that advertising mean for health? We conducted a logistic regression to model the odds of being a problem drinker, which meant drinking patterns that were suggestive of abuse or dependence. And so again, this is an example of Black women. And so the primary explanatory variable of interest here is on that top row, the alcohol ad exposure. So we're basically, mapping where all the ads are in relation to where the women lived in the neighborhood. And after controlling for, so that's the primary exposures. And then after controlling for the other variables in the table, for example, a family history of having alcohol problems, we still found that each additional ad was associated with 13% greater odds of problem drinking. So all that advertising did matter. And so these findings illustrate the importance of understanding contextual factors and fundamental causes and what puts people at risk of risks. Next slide. So I want to continue with this theme of food and drink, but in a quite different vein. So here I'm going to discuss restaurants that use explicitly racist branding, whether in logos, the name, the images, the architecture, all features that are central to the dining experience. Many are aware that the United States has a long history of using racial caricature to sell packaged food. So we all saw recently, right, that Uncle Ben's and Aunt Jemima's came under fire. And actually just 2 days ago, PepsiCo announced that, so PepsiCo owns Quaker Oats, which is where Aunt Jemima brand is. So they just announced that they have new branding, which is, it's now going to be called, instead of Aunt Jemima, the Pearl Milling Company. So this is apparently the name of the company from whence Aunt Jemima actually originated. So in any case, so we all know about the food products, but there are actually a number of restaurants unabashed in their mockery of Blackness, which have remained largely unknown. Next slide. And I came across these explicitly anti-Black restaurants while conducting archival research for the larger book project that Dr. Resnick mentioned in the intro, which is about fast food. And so going down that rabbit hole culminated in the 2019 publication of Burgers in Blackface, Anti-Black Restaurants Then and Now, published at the University of Minnesota Press's Forerunner series for short works. And so this is a screenshot from the ebook. So both this work and then the larger originally planned book came from the NLM funding that I received. So Burgers in Blackface looks at 4 restaurants. I'll just briefly describe 2 of them here, one of which is defunct and the other is still in operation. Next slide. The Coon Chicken Inn opened in the mid-1920s by Maxon Graham and his wife Adelaide. Maxon had obtained a fried chicken recipe and $2,000 from a business deal, which is about $29,000 in today's dollars. And he and his wife opened a modest establishment that sold hamburgers, sandwiches, and other items, basically, quite simple dishes. But the signature dish was the eponymous Coon Chicken. And so the small stand grew into the larger restaurant depicted here. What you see on the left of the image is this large, grinning, winking face of a Black man wearing a porter's cap actually formed the establishment's entrance. So that gap in the front teeth that you see there is the doorway. And so you walk through the mouth to enter the restaurant. As one news report described at the time, quote, "The building has been constructed to represent a Southern log cabin. A huge replica of the head of a colored man, the official trademark of the company, smiles from the front of the building, displaying a row of gleaming white teeth." End quote. The imagery was quick visual shorthand for the idea of Black people in their natural place as servants and cooks, and the racial caricature mocks and dehumanizes Black people. The entrance beckons with the many good things white patrons could enjoy inside, not just a good meal, but also a reinforcement of their whiteness in the nostalgic framework of the Old South. Next slide. The logo actually found its way into Spike Lee's 2000 satire Bamboozled, which I only just realized about a month ago, having watched it for the first time since it was released. This is a screenshot from the Academy Awards website. Next slide. But the explicit racism of the Coon Chicken Inn obviously hasn't gone anywhere. There are ephemera with racist images that continue to circulate. as with this card of Coon's Cooning available on Etsy, so that racism continues to constitute a marketable good. Next slide. And then the second restaurant, so the Coon Chicken Inn is no longer, but it went out of business in the mid 1950s. A second restaurant that employed racist branding was Sambo's, which is still in operation, although it just changed the name. So also, again, in the midst of the sort of racial reckoning that the country's been undergoing, and these brands that came under fire, Sambo's finally decided to change its name. So once a nationwide chain, Sambo's began in 1957 as a pancake house in Santa Barbara. And the owners purported that the name came from an amalgam of their names, but it clearly came from the children's story Little Black Sambo, which was a story first published in the UK in 1899. And so I can say more about the plot if people were interested during the Q&A, but basically the story recounts a little boy's encounters with tigers, and the adventures end in him having a meal of pancakes. So the book, like I said, is published in the UK in 1899, quickly crosses the Atlantic to the US, and is assimilated into the United States racial tropes. And so what's shown here is a serialized version of the story where they were printing the story in segments in the newspaper as a comic strip so that the children could collect them and then fashion their own little booklet out of it. So as we see, Sambo is pitch black. He and his parents are the same color as the iron skillet that his mother wields while making their pancakes. Next slide. And despite repeated protests and even lawsuits over the racist name, the chain thrived for many years before eventually going bankrupt in the early 1980s. It was then revived years later in 1998 by Chad Stevens, the grandson of one of the founders. So he refurbished the original location in Santa Barbara, and then in so doing, reignited all the debates that dogged his forebears. So this is a screenshot from the website of the restaurant a couple of years ago. And so it lasted until just a few months ago when, again, Sambo's finally changed the name. So Stevens has changed the restaurant to Chad's. So I don't know what the website looks like now, but this is when it was still Sambo's. Stevens had until then remained steadfast in keeping the Sambo's name, seeing no harm in it. And this was true for the restaurant's many fans as well. And the idea was that, it couldn't possibly be racist, right? Anti-Black restaurants like Sambo's suggest to America that real racism is maniacal kind of animus. But stereotypes that merely dehumanize Black people can't possibly be racist if they elicit smiles. Next slide. The health risk of restaurants like Sambo's then is not in the food they serve, but in their unabashed degradation of Blackness. Architecture constructed as a physical display of contempt for Black people, or racial epithets in the name, constitute a psychic assault. The subordination of Blackness that these restaurants champion is also what undergirds punitive and restricted health and social policies, and what lies at the foundation of the racial empathy gap that scholars have argued undermine political will to foster health equity. Doctors David Williams and Ruth Williams Morris argued, quote, "The age-old proverb that sticks and stones may break my bones, but words can never hurt me, does not ring true for the effect that believing hurtful words and negative cultural images can have on an individual's health." Next slide. Okay, so Dr. Jonathan Metzl argues in his recent book, Dying of Whiteness, that whiteness is a symbolic good that can mean more than material resources. White men interviewed in his project were vehemently opposed to Obamacare, even when it would save their own lives. So for example, if they had serious illnesses that required care. As one respondent stated, quote, "Ain't no way I would ever support Obamacare or sign up for it. I would rather die. No way I want my tax dollars paying for Mexicans or welfare queens," end quote. That worldview of literally being ready to die and being willing to put one's white body on the line in the name of upholding racial hierarchies, as Metzl puts it, is one key way anti-Black restaurants matter for health, because they casually dehumanize Black people. They embody the racist ideals to which many would rather cleave than to support social reforms that would benefit everyone. Next slide. Okay, so I'm going to turn now to fast food restaurants, where the focus on health has unsurprisingly been more on the nutritional content of the food and the fact that disproportionate densities of restaurants increase chronic disease and obesity risk. So the book project is tentatively titled Painted Black, Race and the Transformation of Fast Food in America, and it too is under contract at Minnesota. So in the book, I examine fast food's racial and spatial trajectory from white, primarily suburban space, and white consumers to Black central city communities. So I came to the project after having published quantitative studies on the distribution of fast food in New York City. Next slide. In this heat map, darker colors indicate greater fast food density across the 5 boroughs of New York City. So at the top is the Bronx, the skinny borough on the left there is Manhattan, then we have Queens, Brooklyn, and Staten Island at the bottom. And so what we found is that outside of commercial and business districts, transportation hubs, and tourist destinations, fast food was most dense in the Bronx, across Harlem, Central Brooklyn, and portions of Queens. So again, where the shading is darkest is where the average exposure to fast food is highest. And we showed that the percentage of Black residents was the strongest predictor by far of this fast food density map. It was not driven by income, was not driven by other kinds of census variables, population density, and so on. And this is a finding that several studies have documented. And though findings are mixed, there is substantial evidence that living proximal to higher densities of fast food is associated with higher BMI and obesity. These studies illuminate, again, what puts Black communities at risk of health risks. And the study that we did here in New York, along with some other research that my colleagues and I completed, both in New York and in other cities, led me to the book project, because the question was, how did these patterns come to pass, right? Because fast food did not locate in Black neighborhoods when it first began. So what was the path that fast food traversed in moving from its origins in white space, urban in the early burger chains like White Castle, and then suburban in later chains like McDonald's and KFC, to become virtually synonymous with Black urban space? So that's the central question of the book. Next slide. Continued higher rates of residential segregation in US cities means that if corporations wish to target Black people as a group, it is an endeavor that's easily achieved. Black neighborhoods are frequently awash in fast food, so much so that some communities have actually enacted legislation to stem the tide. That was the case in Los Angeles in 2008. But fast food actually came quite late to Black neighborhoods. It passed over these communities, not simply because the industry was ignorant or dismissive of a profitable consumer group, though it was, and it did, but also because these communities were incompatible with the racial logics and symbolic meanings of these restaurants. Next slide. KFC and Burger King both preceded McDonald's, but they all came about at around the same time, early to mid 50s, and all of them opened in suburban communities. Ray Kroc opened his first McDonald's in Des Plaines in 1955. Des Plaines is a very white suburb about 20 miles north of Chicago. And so this is what the site looked like in 2013. So this is not the original restaurant, but this is what the restaurant looked like. That the restaurant was demolished in the 80s, and then McDonald's erected this replica. So when it opened for Kroc, intending to seek out a family trade meant all-American domesticity, which meant the unyielding whiteness of mid-century suburban spaces. McDonald's wanted careful investment in the right kind of community, and so that automatically meant conflating family life with whiteness. And so with that in mind, not just McDonald's, but again, Burger King, KFC, and the others left Black communities off the map in citing their restaurants and in marketing their products. Next slide. Or, as this commenter on an Instagram post for the 2016 film The Founder, starring Michael Keaton as Ray Kroc, put it quite simply, so we gonna sit here and act like those ain't start off as whites only burgers. Indeed, they did. The early chains like White Castle literally embodied whiteness in building white temples of hygiene and implied racial purity. Decades passed before the industry realized that Black consumers were an untapped consumer segment. Next slide. Quite a shift McDonald's, for example, made from the all-American whiteness of 1959 Hartford, Connecticut, which you see on the left, to the now defunct Black consumer targeted website 365 Black on the right. African-American communities underwent a transition from a position of market exclusion to a position of market exploitation. So the book will show that it was not a quick and linear path, actually. So fast food made strategic choices about how to engage or reject Black people, both as consumers and as entrepreneurs. It melded with dominant racial currents, eddying around ideas about the products it served, reflecting and pushing forward existing racial ideas and solutions. Next slide. Critically, as fast food began arriving in Black neighborhoods in greater numbers in the 1970s and 1980s, communities vigorously protested their entree, anticipating physical and social disorder, concerns such as loitering, crime, noise, and litter. In most cases, the restaurants were built anyway. But the frequent protests contradict narratives of rapacious demand in Black communities. Nonetheless, whether fast food or soul food, many health researchers study African Americans within a framework of racial tropes that perpetuate ideas about deviance and irresponsibility. Next slide. Media headlines in 2018 extensively covered a study done at the University of Alabama and that was published in JAMA. The study reported that consuming a so-called Southern diet was responsible for entrenched racial disparities and hypertension. The premise was that cardiovascular disease is the biggest contributor of differential mortality between white and Black Americans. And the authors argued that, quote, the reasons for the difference in the incidence and prevalence of hypertension between the Black and white populations remain unknown, end quote. On this point, the authors cited an editorial published in 2011, which highlighted biological differences as potential causes. So that saying that hypertension, that the differences in hypertension were really due to something biological about Black people. And they talked about, the article talked about differences in genotype and discussed the so-called slavery hypertension hypothesis, a debunked theory about Black bodies being predisposed to retain salt after undergoing the Middle Passage. Next slide. But the reasons for differences in hypertension are not really unknown, not in the way that that article suggested. Actually, there's quite a great deal of evidence showing that racism is associated with hypertension. And so this slide shows some of the voluminous literature on racism and African American health, including but not limited to cardiovascular health. And then apart from that, there's also the literature of the Whitehall studies conducted in the UK showing that holding employment where you have less control at work, less authority over decisions, less ability to allocate your time and use of skills is also associated with heart disease and other illnesses. Then there's the literature on John Henryism, the concept offered by Dr. Sherman James, which shows that high effort coping and perceptions that success can be achieved with this kind of bloody-minded determination to achieve in the face of significant barriers and adversity, again, is associated with high blood pressure. Then there's also the literature on weathering, a construct articulated by Dr. Arlene Geronimus, which shows that the cumulative wear and tear of stress, particularly as it relates to racism, literally ages Black people faster. Next slide. And that racism may take the shape of the deeply institutionalized racism that constrains opportunities and heightens exposure to health risk. And then there's also the sort of day-to-day version, right? So as our Black respondents in our New York City study of racism and health reported, they're the more routine interpersonal kinds of interactions that tell Black people that their humanity is suspect. And so that can manifest as rudeness, undue or inappropriate attention, or being treated as invisible or unimportant. So the quotes here are from Black respondents in New York. And as you can see, they're examples of just, that kind of casual disregard for Black people and their experience. Next slide. But the JAMA study sought to investigate the impact of the Southern diet on hypertension. So we're setting aside all the knowledge we know about racism and how that affects health. Okay, so but looking at diet, the Southern diet was defined as, quote, high intake of fried foods, organ meats, processed meats, egg and egg dishes, added fats, high fat dairy foods, sugar sweetened beverages, and bread, end quote. So other than organ meats, which aren't really widely consumed today, that very much sounds like the American diet. And so this reminds me of a great talk actually for this NLM History Talk series, where Dr. Joanna Radin talked about the fallacy of thinking that you're working with raw data, right? So she says, quote, data is always already cooked. So this variable Southern diet is cooked, not raw. It reflects decisions. And the researchers could have categorized the Southern diet as an abundant consumption of greens, okra, beans, root vegetables, fresh fruits, and other foods reflective of an agrarian history and food culture, but they didn't. And so the results, which blared out across the media, fit neatly into existing scripts, that Black people and their cultural practices are always already problematic. So this is why Dr. Adams' statement, the former Surgeon General, about Black people being more likely to have hypertension doesn't actually necessarily look to upstream causes, right? It's probably just about Black people's bad behavior. So another cooked variable in the study was does not exercise. So participants were asked to indicate the number of times per week that they exercised enough to sweat. And this was dichotomized into some versus none. But what if the variable was instead structurally unable to exercise? What if participants were asked, instead of, how often did you exercise enough to sweat? What if you were asked, how many days per week do you leave home early in the morning to begin a long sedentary commute to a low-paying job far from home, work all day at exhausting work, and return home by the same means late at night, right? That would tell you something very different, and it would begin to get at the distal causes of health, making motivational attributions that leave structure uninterrogated. Okay, next slide. But that study and its breathless coverage in the media reveals not only that enduring racialized narratives about Black health behavior make some messages more readily heard and disseminated, but also the converse, that white health behaviors are normalized. Part of what it means to talk about African-American health, as Dr. Kamara Jones points out, is not just the racism that Black folks experience, but also the benefits of myriad advantages and power that are unfairly bestowed to white counterparts. Key among these are benefit of the doubt, trust, laxity in rule enforcement, and day-to-day breaks that most whites fail to even notice. And so in that point, these are screenshots from a 2014 New York Times article titled, "You Probably Don't Want to Look in the Crisper," which revealed what apparently renowned chefs had in their fridges at home. So if we look at these pictures, that included plentiful alcohol, ranging from Pabst Blue Ribbon to champagne, or actually to other kinds of beer and also champagne. Lots of champagne, like really weird amounts of champagne. It's a lot of champagne. What else did they have? They have condiments. They had various kinds of Kit Kat candy bars. Apparently the one there on the top was wasabi flavored Kit Kat. They had donuts that the chef in question admitted to occasionally eating in a bowl with milk like they were cereal, and cookie dough containing rendered lard. And what we don't see much of are fruits and vegetables. But these chefs are given the benefit of the doubt. The article was not reprinted with claims about the danger of the white diet and racialized conceptions of moral failure. Whiteness lends normalcy to behavior and confers expectations about the kinds of benefits that ought to be realized in day-to-day life. Next slide. My colleague Melody Goodman and I found evidence of this in a study in Boston. So we took note of an interesting finding in a study by Dr. S.V. Subramanian and colleagues. And they found that metro areas that had higher probabilities of poor health for whites were those in which the white-Black health disparity was narrow. In other words, the absolute health of whites was better where they held a larger relative advantage to black counterparts. And why might that be? So perhaps the psychological wages accrued from whiteness benefit health. Poor whites may face health risks not merely due to meager resources, but also because being poor disconfirms expected rewards from being white. If whiteness confers expectations of privilege, then whites may fare better when the relative gap to blacks is larger, because those gaps are consistent with settled expectations of whiteness. So in Boston, we examined 3 neighborhoods that could be characterized as rich, richer, and richest. The median incomes in the 3 areas are superimposed there, photos from the streetscapes. And in the 2 most affluent neighborhoods, which were also the most racially homogeneous neighborhoods, white residents who perceived Black people to be welcome in their communities enjoyed better self-rated health. In contrast, in the least rich neighborhood, where there was greater economic diversity and many more Black residents, those same perceptions at best conferred no health benefits, or at worst they were associated with poorer self-rated health. It may be that those residents unable to realize the norm of exclusionary white space experienced a relative social status where whiteness was more precarious and therefore harmful to health. Next slide. The study findings suggest that adherence to and reliance on a racialized social system that puts whiteness at the top of the hierarchy harms white folks too. The COVID pandemic has thrown into bold relief how damaging the subtle expectations of whiteness can be. Mask wearing, for example, a simple and effective way of reducing the spread of the virus, has been a politicized and racially contentious issue. Pew reported in June and August of 2020 that white and Republican respondents were the least likely to regularly wear masks. And then this slide shows data from October 2020, in which Republicans accounted for 92% of those who expressed skepticism or opposition to masks. And you just have a couple of the quotes of why people thought so on the slide. The fact is that wearing a mask to protect other people is simply not compelling when the most vulnerable are often Black and brown. Just last month, the Washington Post reported on restaurants in Michigan that have been ignoring public health guidance, filling to capacity and eschewing masks. These restaurants have enjoyed bustling crowds, many of whom come from hours away as tourists, seeking the company of others who disdain masks. One particular owner received a cease and desist order from the county health department, and the restaurant continued to operate unrepentantly. When the sheriff showed up, the owner queried what his punishment would be, and the sheriff replied, quote, "Nothing. I'll be seeing you tomorrow for coffee and breakfast," end quote. We have heard arguments that wearing a mask infringes on individual liberty. How then should we understand liberty? Next slide. Tracy Mears, a law professor at Yale, has argued that, quote, "At its base, liberty is freedom from fear. And for too many people, especially right now, many people of color are afraid of all kinds of things that they ought not be afraid of," end quote. So here she referred to such fears as being killed by the police. In the context of COVID, many circumstances exist that we would rather Black folks would have no cause to fear. Black people are not afraid of the dark, unless that darkness is defined by fellow Americans who would rather die for racial hierarchy than to live for the interest of the public's health, unless it's a state, under the previous administration, that could fully abdicate its role in protecting the safety and well-being of the populace as hundreds of thousands died, or unless it's having to watch Black deaths be tallied but not counted. The pandemic has brought into sharp focus what it means to talk about African-American health risk is to talk about the fate of the nation. When James Baldwin was interviewed by Dick Cavett in 1968, Cavett asked why Black people weren't more optimistic given the substantial progress that they had been made, so that we had Black mayors and Black sportsmen and so on. And he queried, quote, "Is it at once getting much better and still hopeless?" And so Baldwin replied, quote, "Well, I don't think there's much hope for it, to tell you the truth, as long as people are using this peculiar language. It's not a question of what happens to the Negro here, to the Black man here. That's a very vivid question for me, but the real question is what's going to happen to this country. I have to repeat that," end quote. Next slide. So I will stop there, and I want to acknowledge the grants and fellowships that made the studies I discussed and the recent book projects possible. Unfortunately, I can't fit all the research staff and wonderful collaborators who also contributed, but they have my thanks as well. And yeah, I look forward to questions.
Dr. Kwate, thank you very much for that very important and engaging presentation, and congratulations on your research. Thank you very much. We do have some time for questions, and I have received several. I'd like to remind everyone watching that there should be a send live feedback button on the live stream. If you don't see it right below the video, simply refresh your browser and the button will appear. You can send questions via that button, or if you're on Twitter, you can direct message me if you wish. So among the questions we've received, the first one is, in research looking at smoking and health risk, many studies suggest that per pack years, Blacks do worse than whites. Some believe this may be the menthol effect. Others also suggest that Blacks smoke shorter cigarette butts than whites. What are your thoughts on this difference in pack years compared to health risk by race?
Well, I have to say I am not a smoking expert, but I know that, right, this is the same kind of thing that comes up with alcohol, is that, you know, Black people may consume, they may be less likely to drink, but they still face worse health outcomes from the drinking that they do. And I think that just speaks to the broader context of, what puts people at risk of risk, that there are a number of structural factors, operating to worsen health outcomes, even if the behavior itself may not be at the same level of severity as others.
Thank you. Understood. Another question that we received, thank you for this excellent, albeit disturbing presentation. This person writes, how do you reconcile the aggressive advertising of alcohol in predominantly Black neighborhoods with the survey results indicating that fewer African Americans drink regularly as compared to white Americans?
Yeah, I mean, so there's that's the important mismatch, is that it's clearly not driven by demand, right? So that's the point I think I want to make clear, is that when you see all of that advertising, or if you see in the case of, for example, liquor stores, which are also consistently found to be disproportionately dense in Black neighborhoods, and that they're not attributable to income, is that the immediate sort of thought is, okay, well, then it must be because those are the communities where there's the greater demand. But we know that not to be the case, both from the consumer data and from the health data. And so it reflects a number of things. I mean, it reflects companies seeking more consumers for products. So for example, with smoking, they were very deliberate in recognizing that as smoking rates decline, they needed more Black smokers to take up that slack. With alcohol, it's the same kind of thing. Some of it is just disregard for the community wishes. So that's why you see communities having to engage in whitewashing. There's no demand. They don't want the advertising there. They don't want the products. But the corporations that are interested in their bottom line have an entirely different set of goals or needs than what the community does.
Thank you. Just a more basic question. Several individuals have written to say this is a fabulous and informative presentation, fact-packed, and someone even wrote triple excellent. And on the heels of that, I'd like to say to these individuals who kindly wrote in, this will be archived, this talk, as are all of our history talks here at the National Library of Medicine, and available through the NIH video casting system. So yes, this talk will be archived and available probably within a couple of days. Dr. Kwate, another question. You mentioned that some communities, notably Los Angeles, took steps to stem the tide of fast food restaurants moving into and exploiting African-American neighborhoods. What did that look like? Can you say more? And what did these communities do to try to stem the tide?
Yeah, so that was actually, so the Los Angeles case is really interesting. So this was in 2008, and essentially what happened is the city council proposed legislation that, so they created an ordinance that started out as temporary and then became permanent after that. but the ordinance was meant to prohibit the entree of additional fast food restaurants in communities that were already heavily saturated. So this was South LA, Baldwin Hills, Lamert, and East Los Angeles, I think. And but what happened was, it wasn't, so, on the one hand, it was a really interesting kind of intervention, but on the other, it was also limited because of the way that it was defined. And, that was probably a reflection of the fact that they didn't want to be seen as engaging in like a total overreach. But basically, it said, okay, you can't have new restaurants that are freestanding, like sort of, if you think of like a fast food restaurant on the corner with a drive-through and the whole thing. So it prohibited new freestanding restaurants that from coming in, but that didn't mean no new restaurants at all. So you could still have fast food come in if it was, say, in the strip mall, right? So then it's not a freestanding restaurant. And it also obviously didn't. Oh, and it also prohibited, though, expansions of floor space, and it also prohibited adding a new drive-through window to an existing restaurant. But so, on the one hand, it's making it impossible for new restaurants to come in a particular, a very narrow kind of set of criteria. And so the densities that the fast food density that those communities were dealing with wasn't necessarily lessened. The idea was, they thought, well, if we can, stem the tide and sort of reduce the number of fast food restaurants that are coming in, that might open up the possibilities of sit-down restaurants and a wider range of healthful options that they saw were more present in West Los Angeles and other communities that were predominantly white. But that didn't really happen, and that's a reflection of the fact that Black and brown neighborhoods are redlined for all kinds of retail. And just because you target a reduction in fast food, that's not going to eliminate the racism that keeps the other restaurants that you want from it's not going to attract them to come in, right? Just because that other set. So it was both pro and con, but I thought it was a really interesting and an important kind of intervention that was made from the community, was determined from the community. Yeah. Thank you.
We have a couple more questions, if you don't mind. You could stay with us. We'd be grateful. There has been an increasing interest in the literature about the effects of childhood toxic stress on lifetime health outcomes. Did your research happen to look into the manifestations and impact of racism on children in Black communities?
I have not. I would suggest, who are some people Dr. Eleanor Seaton, off the top of my head, I'm blanking, but there are a number of researchers who have looked at racism and health child and adolescent developmental stages. I haven't personally, but they do, but it's the same kinds of issues and core concerns that you see in the adult populations.
Thank you. Another individual has written in, extremely important work, well presented. Thank you. You showed some data regarding impact of advertising. Is there data on educational approaches that are more effective in combating advertising?
Well, so we were doing the first, to our knowledge, study looking at how the outdoor advertising actually affected behavior. So there had been a number of studies to show that the advertising was disproportionately dense as a function of race, but hadn't actually made the link to what's the impact on behavior. So any of that literature that you see around education and is probably going to be more around like print, or it's going to be focused on youth, and it's not actually looking at advertising in the built environment itself. And I think what's important is that, so in our study we did, it's hard to tease apart. I mean, we found that the more ads there were, the more likely you were to have the odds of having a problem drinking. But the mechanism for that is unclear. So is it just the numbers of ads, or do you have to, or is it something about the messaging that's in the ads, or like there are a number of aspects about that advertising that could be affecting behavior. And so yeah, if you were going to develop something from an educational perspective, you know, which of those aspects would you need to target would be the question. So that's not a step we have taken personally.
Thank you. I have two more questions, and they're related and they're important, and I'd like to ask them. Both of these individuals, thank you very, very much for your presentation. What would your findings and conclusions apply to any marginalized group in the United States, to Native Americans, to Latinos, this person writes. And the other individual writes, how are we to change the systemic inequality within the system? And what can individuals do in their own lives to make change? Great presentation, thank you.
Thank you. Well, so I would say some of what I've discussed, I mean, the fact that racism harms health is something that has been shown in different marginalized communities. That is true. I wouldn't say that the specific findings that I reported on should be generalized in the same way to all the populations, because there's specificity in what, what racism looks like. And again, what I was trying to show was that, excuse me, some of those longstanding racial tropes that are specific to Blackness that can still continue to operate today and are manifest in these different kinds of unique and specific ways that affect Black people. So I wouldn't want to try to say that you can just pick those up and apply them to all groups, because that's not the case. Although again, experiencing racism has been shown to be harmful to health from people from different other backgrounds other than African American or people of African descent. And then as to the question as to how do we change the system, I mean, I think it depends on what the system is, so that, clearly what we see happening right now in terms of, the protests that have by some measures been seen as the largest in US history. I mean, I think that kind of action is important and necessary, and we're seeing the impact of it. But I also think that if you're talking about, how do we change, for example, what we see in healthcare, where Black patients are more likely to be, receive disparate kinds of care in this one realm. How do we change the system as it relates to education, as it relates to housing, as it relates to retail, as it relates to, there are so many different endpoints for that systemic work that I think what individuals should do is really, based on where they are, is try to make a change based on what to be unjust in whatever realm, whichever system, you can act. You may not have access to making a difference in healthcare, but I think starting small in your community or in school systems and so on is where people can make their most direct connection.
Thank you, Dr. Kwate. And on that very important note, I want to thank you again for an outstanding presentation, for taking the time to prepare it and present it today. We had over 400 viewers remotely, and it's a testimony to the importance of your work. And we look forward to your future publications coming up soon, and look forward to keeping in touch. Thank you again very, very much, and wish you much success in the next steps in your research. Thank you.
Thank you. Thanks, everybody.